I would like to thank Dr. Vees for the privilege to join this 50th anniversary and share our work. Disclosure. Patients with infected aortic aneurysms have at least two problems. Infection of the aorta that leading to weakened aortic wall that may eventually rupture. We reported our early experience in 2011, 12 years ago. Before and after that, there were numerous reports of the treatment in infected aortic aneurysm, including a few systematic reviews. Most of the reports indicate good short-term and mid-term results. However, there are concerns about the long-term outcome and the incidence and type of late complications. In the 17-year period, we have treated 163 infected aortic aneurysm patients at various levels as shown here. We will give IV antibiotics for 2 weeks after the procedure. If clinical improve and good re-CT scan, we will switch to lifelong oral antibiotics. But if not improved, we will reconsider antibiotics based on the organisms found in our region. 85% was non-fistula group. They presented quite late in our region, and in all segments of the aorta, the mortality in this group was 7.9%. 15% presented with fistula complications. There were aortoesophageal fistula, aortobronchial, aortoenteric, aortocaval fistulas. The mortality rate was 29% in this group. Altogether, the mortality is around 11%. When we look at the non-fistula group, the most common cause of death was sepsis. Rebleeding is the most common cause of death in the fistula group in hospital mortality. With the average follow-up of 47 months of the 145 survived patients, majority of the patients had significant or complete sac regression. That was 86%. 9% had aneurysm sac stable, and only 5% had aneurysm growth. This is one of our early cases treated with good results. Sac regressed quite quickly, and this patient survived for almost 11 years and died from stroke. Another patient had quite good result also, still doing very well currently. And this infected arch aneurysm, we treated with a hybrid procedure for him, good results, aneurysm shrunk, and he survived to almost 9 years. He died from heart problems. Multiple level infection also can have good outcomes, and as shown here in this patient. There were 17 patients had recurrent disease, 11.7%. Of these, majority of the recurrent disease were recurrent aneurysm at the edge of the device, either proximal or distal. Recurrent bleeding and reinfection, they did occur, but not that common. This patient had infected aneurysm close to the renal arteries. We did chimney EVA for him, 2 renal arteries, chimney. Good results, as shown here at 1.5 years CT scan. He came back 1 year later with severe back pain. Diaphyseal aneurysm recur at the edge of the proximal stent, almost 2 centimeters above the previous lesion. We had to extend the cuff proximally, chimney the SMA, extended the 2 renal chimneys. Good results, still doing well. This patient had distal aortic dilatation, and we treated with bifurcated graft extended distally, still doing good currently. This patient has distal aortic dilatation at the proximal, at the distal stent graft. We had to distal extension with the custom-made device. We cover celiac axis in the first procedure, so it is a 3-branch CMD. Recurrent bleeding did occur, not that often. This is happened in our very early experience, and we thought that because we did not cover far enough proximally. And this patient actually did well up to 5 years follow-up, but she lost to follow-up and came back 3 years later with severe infection, recurrent at the abdominal aorta, failed to medical treatment, so we have to explant. So in conclusion, Chairman, ladies and gentlemen, we believe that endovascular therapy is effective treatment for infected aortic aneurysm, and both short and long term. And 86% of the patients during the follow-up had significant or complete aneurysm sac regression. Average follow-up was almost 4 years. There were 2 types of failure. And we believe that most common failure related to the procedure, the technical, that we did not cover far enough. We believe that it may be preventable. Infection-related recurrence did occur, serious, but not that common. Thank you very much for your attention.